Hello. I'm going to be going over a lot of high-yield endocrinology topics today. So I have a full list that you can refer to at the end of the video. This is just going to be a table of contents. So we're going to try to hit on all the high-yield board relevant topics. So let's get started. So first, pituitary gland overview. So known as the master gland because the pituitary is able to synthesize all of its own hormones. Typically, it's located up here in the sella turcica of the sphenoid bone. It's connected to the hypothalamus via the infundibulum. And there's two different portions. So there's the anterior, which is also called adenohypophysis, and then the posterior pituitary. So a few buzzwords to think about when you look at pituitary hormones would be bitemporal hemianopsia. So the pituitary can sometimes compress upon this optic chiasm here, and so it'll cause visual defects, and that's a common trigger or buzzword that's usually seen on board exams with this. So, going through the hormones that the anterior pituitary makes, the mnemonic for this is flat pig. So, FSH, LH, ACTH, TSH, prolactin, and growth hormone. So, FSH stimulates the follicles, helps with spermatogenesis. LH is for more so ovulation, testosterone production as well. ACTH, it's cortisol release, comes out of the adrenal. It simulates the adrenal cortex to release the cortisol. Then you have the TSH, your thyroid hormone, which simulates T3, T4. There's also prolactin, helping milk production. And then whenever you have an abundance of dopamine or using dopamine agonist drugs, it can suppress this. So some of the regulations. So thyroid releasing hormone causes thyroid stimulating hormone and prolactin to be increased. Corticotropic releasing hormone causes ACTH to be released. GnRH causes an increase in LH, FSH. And then dopamine, like I mentioned earlier, it inhibits prolactin. And finally, the somatostatin analogs, somatostatin inhibits GH, growth hormone, and thyroid stimulating hormone. Posterior pituitary, there's only two separate things for it. So there's ADH, which is vasopressin. It acts on the V2 receptors in the kidneys, helping to reabsorb all that water. It also acts on V1 receptors and causes vasoconstriction. Then you have oxytocin, made in the paraventricular nucleus, and it stimulates uterine contraction as well as milk letdown, so the ejection of milk. So one of the mnemonics, ADH adds H2O. So if that helps, that would be a helpful mnemonic for this. Then we have pituitary disorders. So one of the ones here are prolactinoma, one of the most common ones. Symptoms you'll see with this are galactorrhea, amenorrhea, decreased sexual drive, libido, and then some of the treatments for this would be cabergoline or bromocriptine, which are dopamine agonists. Another disorder would be acromegaly if you have too much growth hormone. This can be seen in kids having enlarged hands, jaws, organs, or in kids where it causes gigantism. Another thing is labs to look out for. You'll have increased IGF-1, and the treatment for this is octreotide, which is a somatostatin analog. Next, we have Sheehan syndrome. Typically, this happens after an infarct when a person is pregnant right after childbirth. And some of the things you'll see with this are failure to lactate, amenorrhea, tolerance to cold. So another thing is empty sella syndrome. This is just due to atrophy, um, either atrophy or compression of the pituitary gland. So typically seen in obese women, or it could just be unknown origin, or possibly there was having radiation to that area, and so that also caused atrophy. All right, so diabetes insipidus. So central diabetes insipidus, it's due to a decrease in ADH secretion from the pituitary. And if you're having nephrogenic, then ADH is still being secreted, but kidneys are not responsive to ADH. One of the treatments for this one here is just giving desmopressin for the central, because ADH is not being secreted, but you can give desmopressin and have the system working again. Whereas in nephrogenic, giving desmopressin will not do anything because the kidneys are not responsive to it. So some of the symptoms and key phrases you'll see are like polyuria, polydipsia, or dilute urine. Um, okay, so SIADH, it's an excess of ADH, which basically just reabsorbs all your water, and so you'll get dilutional hyponatremia, low serum osmolality. Some of the key things that will cause this are small cell lung cancer, any brain injury, certain brain injuries, and then drugs like SSRIs or carbamazepine is one of the ones known to cause it. Um, Treatment for this, typically they just do fluid restriction, or you can give domecacycline. That's another drug that would be helpful in this. All right. So moving on to thyroid hormone, the production and regulation of it. So TRH, all the way from the first top portion, TRH is released from the hypothalamus, goes to stimulate TSH. TSH then stimulates T3, T4, causes iodine to be taken up into the follicular cells, and then that gets oxidized by TPO. And TPO also helps in the formation, or helps to catalyze in the iodinization of thyroglobulin, and that makes T3 and T4. So T4 is typically more abundant, T3 is the active form, and it's converted in the periphery by 5' deiodinase. And if you have a lot of T3, T4, you'll get negative feedback suppressing TSH and TRH. Okay. And you can suppress thyroid peroxidase. So this enzyme up here that can be suppressed by using PTU or methimazole if a person has symptoms such as Graves' disease where they're having exophthalmos or hyperthyroid symptoms. So hypothyroidism, you'll see cold intolerance, weight gain, bradycardia, dry skin. Typically they'll have a high TSH because T3 and T4 are low in primary hypothyroidism. Some of the causes would be Hashimoto's, so it's an autoimmune, anti-TPO, anti-thyroglobulin antibodies. Typically, it's painless, typically seen in middle-aged women. Histology, it's linked to the Hurlithial cells, um, and there is a risk of non-Hodgkin's lymphoma with this as well. So, congenital cretinism, that one can cause intellectual disability, coarse facies, and an umbilical hernia as well. And then, let's see. Yeah, so some of the buzzwords here. So if they have a painless goiter plus anti-TPO, if that's mentioned in the question stem, it's kind of pointing you towards Hashimoto's. Next we have hyperthyroidism. Opposite symptoms, heat intolerance, weight gain, tachycardia, all those types of things that you'll see. And this one will have high T3, T4, and low TSH in primary. So some of the causes for this would be Graves' disease. It leads to TSH receptor stimulating antibodies, which is the cause of this, leading to exophthalmos, pretibial myxedema, diffuse goiter. Yeah, so Some of the other things that can happen with it are thyroid storm. Some of the other causes could be a thyroid storm, which is just life-threatening hyperthyroidism, arrhythmia, fever, agitation, and then toxic goiter or thyroid adenoma could also be a cause of this hyperthyroidism. Treatment, typically we just use methimazole as first line. Propylthiouracil is used if the patient is pregnant in the first trimester. After the first trimester, you can use methimazole. And then beta blockers are also used for symptom relief as well as steroids. Okay. So some of the thyroid cancers. I'll go over types and then key features. Papillary, one of the most common types. Key features with it are orphan antinuclei, psammoma bodies, and nuclear grooves. Follicular, um, this one, it's a little bit more dangerous. It invades the blood vessels, but it doesn't get into the capsules, and it spreads hematogenously. Then you have medullary. This one arises from the parafollicular C cells, causing a release of calcitonin, and this is seen in MEN2A and 2B syndromes. Okay. So yeah, papillary, some of the key buzzwords are if you had radiation exposure or psammoma bodies, and then medullary would be MEN2A or 2B syndromes. So moving on to parathyroid hormones and calcium regulation. Parathyroid hormone, it's secreted in response to having a low calcium. It causes an increase in the osteoclasts, which break down the bone, release calcium. Calcium is reabsorbed in the kidneys as well in response to PTH. The kidneys excrete a lot of sodium in response to this, and it also stimulates 1-alpha hydroxylase, which converts to the active form of vitamin D, which is calcitriol. So calcitonin from the thyroid C cells will also lower the serum calcium because it draws calcium in. So yeah, calcium and PTH are kind of in a feedback loop here. So calcium goes up, PTH goes down. Same kind of concept there. All right, parathyroid disorders. So you have primary hyperparathyroidism, typically due to a parathyroid adenoma. When you have high PTH, high calcium, decreased phosphate. So some of the symptoms you'll notice that they'll say are stones, bones, groans, psychiatric overtones. And then you could have secondary hyperparathyroidism. So due to chronic kidney disease where you have low vitamin D and calcium causing PTH to be high in response to these things being low. So you'll see high PTH, low calcium, high phosphate. Because PTH is high. Um, it's because calcium is low, PTH is high, and phosphate's high because chronic kidney disease is not being able to excrete out phosphate. Then we have tertiary hyperparathyroidism. So this one's just refractory hyper-PTH due to a long-standing secondary version. So you'll see high PTH and high calcium as well. Hypoparathyroidism, decreased PTH, decreased calcium. It causes tetany and muscle spasms. You'll see the Trousseau and Chevesque signs, which are cheek twitching when you tap somebody on the cheek, and then Trousseau sign, hand spasm, once you put on a blood pressure cuff. So, adrenal cortex layers and their hormones. So, the mnemonic for this is salt, sugar, sex. So you're starting out with the zona glomerulosa, the mineral corticoids. So the salt, it's regulated by the RAS system. Then you go in further, zona fasciculata. This is the sugar, so glucocorticoids regulated by ACTH. Then finally, the inside, the androgens. And this one is also ACTH stimulated. So cortisol, some of the functions of it are just it'll increase your blood pressure, decrease inflammation, decrease glucose uptake, so it increases your blood sugars, um, decreased fibroblast activity, you'll have poor wound healing, decreased immune cell function, and decreased bone formation. Next, we're going on to the adrenal disorders. So we have Addison's disease, as well as secondary adrenal insufficiencies. So Addison's the primary. It's where you have destruction of the adrenal cortex, causing low cortisol and aldosterone. Causes could be autoimmune or just TB is the worldwide cause of this. So symptoms, you'll have hypotension. Also hyperpigmentation is important here because you'll get high ACTH, which causes MSH to be pretty high, leading to the hyperpigmentation. You also have fatigue, salt cravings. Labs will show low cortisol and high ACTH, as well as hyponatremia and hyperkalemia. Because sodium and this work opposite. So when one's low, the other one's high. That's the kind of feedback that they have. Okay, so secondary adrenal insufficiency, basically decreased ACTH from the pituitary. And then you'll have low cortisol and a normal aldosterone since the RAS is still intact. No hyperpigmentation with this, because there's no POMC being released, and no hyperkalemia either. Tertiary adrenal insufficiency could just be due to chronic steroid use where you suppress that axis. And so if you're trying to taper off somebody, you want to do it slowly. Otherwise, it could lead to an adrenal crisis if they've been using it for a long time. Because the whole axis is going to be suppressed here. So the only place that they're getting their steroids is from the exogenous use or wherever they're injecting from. So then we have Cushing's syndrome, so excess cortisol. Some of the causes would be exogenous steroids, ACTH adenomas, ectopic ACTH from a small cell, and then adrenal adenoma. Symptoms you'll see with this are like moon phases, obesity, buffalo hump, thin limbs, osteoporosis, those kinds of things. And workup, in the first step, you do a 24-hour free cortisol or a low-dose dexamethasone suppression test. If you're seeing that that's abnormal, then you check the ACTH. Because ACTH, if it's high, then it's a pituitary versus ectopic problem. If it's low, it's an adrenal tumor or an exogenous steroid use. Next, we have hyperaldosteronism. Causes for this, Conn syndrome, primary thing. It's an adrenal adenoma causing high aldosterone, leading to hypertension, low potassium, metabolic alkalosis, and then because potassium would be low and hydrogen ions would be low, so you get alkalosis. And then renin would be low. Okay, so next would be secondary hyperaldosteronism, high renin, causing hypertension, and it's renin secreting tumor. Congenital adrenal hyperplasia, so it's autosomal recessive enzyme defects. Most common is 21 hydroxylase deficiency, but these are the different types of deficiencies that you have here, 21, 11, 17. So 21, if you get that, you'll get low aldosterone and cortisol. 11 will only cause you to have weak mineral corticoid. It still has weak mineralocorticoids, but increased androgens. And then 17, alpha hydroxylase causes you to have low androgens and cortisol, but the aldosterone's okay. So one of the key buzzwords is if you see virilization with a newborn girl with salt wasting, you'd want to think of 21 hydroxylase deficiency because everything is being shunted over towards the end to cause the virilization to occur and more androgens to be made. Okay. Next is the adrenal medulla and pheochromocytoma. So these are derived from the neural crest cells, secrete catecholamines like epi and norepinephrine, and they're stimulated by a CH from the sympathetic preganglionic neurons. So a pheo, that's a tumor of the chromaffin cells in the adrenal medulla. You'll have hypertension, palpitations, sweating. There is a rule of threes here, not very important, but uh, something to be aware of. So, treat or diagnosis, you'll be looking for excess metanephrines in the plasma or urine, and you use phenoxybenzamine, a non-selective alpha blocker, then beta blocker, and then surgery. You want to use alpha first before beta, because if you use beta, then you'll get unopposed alpha blockade. Or unopposed alpha. And so you don't want to do that. Go in this order. It'll lead to a hypertensive crisis. All right, so diabetes type 1 versus type 2. Type 1 is due to an autoimmune destruction of the beta cells in the pancreas, typically in kids, related with HLA-DR3 and DR4, and causing an absolute insulin deficiency. So they are going to have DKA in this. Symptoms, polyuria, polydipsia, and weight loss. Type 2 will not have DKA. It's due to actually insulin resistance, so you'll have a relative deficiency. Onset, it's a little bit later. It's in adults or obese patients. There's a genetic component, and an increased risk of stroke, microvascular retinopathy, nephropathy, those kinds of things. And in order to diagnose it, you want to get a fasting glucose over 126 or an A1C over 6.5 or a random glucose over 200 plus having symptoms. And then you can do a 2-hour glucose tolerance test. And if it's over 200, that's also indicative of this. So having DKA versus HHS, DKA, the glucose levels are typically a lot lower and they're seen with type 1. So DKA is around 300 to 500. Once you get over 600, it's HHS. Some of the symptoms like Kussmaul's breathing, fruity breath, and then this one will just have dehydration and altered mental status. Treatment, kind of similar, both IV fluids, but this one you'll use this one you use potassium as well, and in both of them insulin is used. So, one of the things for DKA to look out for if the potassium is low, but serum potassium might still appear normal, so you have to do the corrected calcium in order to make sure that it's actually not too low. Okay, and then diabetes medications, just a high yield overview. Rapid acting are Lispro, Aspart, and Glucine. These are given at mealtime. Short acting would be regular insulin. And then intermediate would be NPH. Your long-acting insulins would be Glargine and Detromere. And this is for basal control. So for the whole day, you want to give these. These last like 16, 24 hours. Side effects from some of these drugs are hypoglycemia, weight gain, and lipodystrophy. Okay, so now looking at the oral hypoglycemics, there's a little bit of a table here to be able to summarize classes, mechanisms, and then key buzzwords to look out for on a test. I will go ahead and tell you, so we'll go through the key buzzwords here. So first line in type 2 diabetes mellitus is always going to be metformin because it's weight neutral. The only real side effect of this is just lactic acidosis risk. Sulfonylureas, they can have a risk of hypoglycemia. If you're using the first gen ones, thiazides, the glitazones, they can cause fluid retention, CHF, weight gain. DPP4 inhibitors, these are typically well tolerated. You might have a little bit of weight loss actually with these. And DPP4 and GLP-1s kind of work in a similar manner. They increase the incretins, the GLP levels, which cause your body to which cause your body to release insulin on its own. And then GLP-1s mimic the incretin. So, pancreatitis is a risk factor for GLPs. For SGLT2 inhibitors, some of the common side effects are UTIs, yeast infection, um, and weight loss. For meglutinides, they're shorter acting. The risk is just hypoglycemia. And then alpha glucoside, these ones, the side effects are flatulence or diarrhea, because they delay the carbohydrate absorption in the intestine. All right. Next, we have the MEN syndromes. So, MEN1, 2A, 2B. For the first one, think of them by the three P's. So, parathyroid, pituitary, pancreatic. Next, you have medullary thyroid, pheochromocytoma, and parathyroid. So, the next one after that is similar, starting out medullary thyroid, pheochromocytoma, with no parathyroid. Now it's mucosal neuromas and marfanoid habitus. Medullary thyroid cancers do produce calcitonin as well. And another key point is just if you have a RET mutation, you want to screen for a RET mutation before you're doing any sort of thyroid ectomy. Okay. Moving on to reproductive endocrine PCOS. So with polycystic ovarian syndrome, you'll have high LH-FSH ratio, 2 to 1. The high androgens will cause you to have facial hair and acne, and then inability to inovulate, and it's associated with insulin resistance as well, so you'll get obesity. So, some of the labs, you'll see high testosterone, high LH, and low FSH. And a key imaging thing would be like a string of pearls, if you're doing an ovarian ultrasound, if they mention that in a question stem. Treatment for this, weight loss, oral contraceptives, spironolactone, and metformin. Uh, if you want to have a mnemonic or a way to think about PCOS, typically it's fat, hairy, and irregular periods is kind of the type of patient that they would give you. Now we have Klinefelter syndrome. So Klinefelter's is a male with an extra X, so you'll have XXY. It causes primary hypogonadism, so the male will have low testosterone and high FSH, LH. You'll typically see a person who's tall with long limbs, small testes, infertile. They have breast enlargement and learning difficulties. So these are some of the key buzzwords to think about when you're looking for Klinefelter. Another one is Turner syndrome. Turner syndrome is 45XO. It's a female with a single X chromosome. So some of the symptoms you'll see are short stature, a webbed neck, shield chest, widely spaced nipples, streak ovaries causing amenorrhea and infertility, and then a coarctation of the aorta, as well as a bicuspid aortic valve. And some of the lab values, you'll have low estrogen, because of the streak ovaries. And then if you have low estrogen, then it'll cause your body to make more LH and FSH to try to make this higher. These are the buzzwords that I was talking about with Turner syndrome. And then finally, I just have a endocrine like buzzword cheat sheet for you to look at. This is rapid review for the exam. So stuff like for Graves' disease, you need to think of exophthalmos, pretibial myxedema, and Hashimoto's, anti-TPO, Addison's hyperpigmentation, central obesity here. So some of these types of things, MEN syndrome 1, pituitary pancreas parathyroid. Um, and yeah, so these are basically all the things we kind of went through, but in a nice little table format here for you to review some of the buzzwords. And yeah, this was pretty much the review for endocrinology, all the high yield facts that you would need to know. And I hope this was helpful. So thank you so much.